In my analysis of the burn device and the burn space, I guess one thing I'm wondering is what is the most common type of burn and how does it happen? What do you see in your practice that comes across that comes to the emergency room?
So it very much depends on the age of the patient, as the causes tend to be different. So for kids, commonest cause is scalding from hot liquids, often from pulling down cups of coffee or tea, or even pans from the cooker. And that's when they start getting mobile. They're reaching around their environment, they're exploring, therefore they're more likely to latch onto things and pull them over themselves. Contact burns are also common in children, touching hot radiators. Maybe they're going to get some biscuits out of a top cupboard. They climb and they walk across a hot cooker,
Hmm.
or they touch an oven door. And because they lack the withdrawal reflex to pull away from a noxious stimuli, they tend to stay there. And that stimuli is something that we develop with age. In adults of working age, you tend to see more flame burns and scalds. Um, but environmental changes means that those injuries tend to occur in the working environment as well as the home. So you see sort of an evolution of the etiology of the burn and a difference in the location. Unfortunately, drug and alcohol problems are overrepresented in our
Hmm.
patient community, and they will feature in a proportion of patients who sustain a burn either accidentally or intentionally as well.
Okay. Yeah, and I think it's been a while since I burned myself. I mean, I think it probably hasn't happened since I was a kid. Is there, when you look at the proportion of individuals who are burning themselves, is it much higher in children or, and obviously there are certain, professions that probably are having burns at a higher rate. What do you see there?
So we tend to see a trimodal distribution, so three peaks. The first is in children as they start cruising, exploring the environment, as I said, reaching for things, but they're not having that awareness of risk. The second peak is in young risk-taking men, um, and that can stretch anywhere from teens through to young adults. So I'm thinking about that MTV show that was on in the early
That's
2000s.
exactly what I was thinking too.
Yeah, yeah. Uh, and the third peak is then the elderly. So those who are frail, they may have other comorbidities. They've fallen in the shower or bath. They become unwell next to a hot radiator. And certainly in my practice, we're seeing a huge increase in the number of elderly patients sustaining
Hmm.
significant burns. I think the critical thing with kids is that they have thin skin and less
Hmm.
heat is needed or less
Right.
contact time is needed for them to sustain a very deep burn. Children with major burns can then become critically unwell very quickly and from smaller burns than in adults, and they're much more prone to invasive infections, things like toxic shock syndrome. And a really important point with the kids is that there's a wealth of data to support earlier wound healing, as the risk of them developing hypertrophic scarring is higher than in adults. So, for that reason, we advocate complete wound healing within 2 weeks. Some experts promote it even earlier, and that reduces the scar burden long term and achieve a better outcome for them. But even beyond that, it's not just about skin injury. Burns can have a dramatic effect on the whole physiology of a patient, metabolically, immunologically, and psychologically. There's a huge amount of data looking at cohorts of kids, and it increases their risk of loads of different diseases in later life if they've been burnt as a child. So it is a life-changing event.
DeepView's been evaluated in the United States, the UK, and Australia, and I think you've actually done work in Africa. What's the difference in types of burns in these different regions? I'm thinking, in Africa particularly, uh, there's a lot more probably open flame cooking. I'm not sure if that plays a role, but I'd love to hear your thoughts on kind of how it varies by region.
Yeah, so I've worked in UK and Australian burn care, and I think the source and type of burn injuries are very similar. And I probably expect a similar pattern in the US and other high income countries. But yes, I'm involved in some work in Africa. I go to Tanzania, and the pattern is very different in lower middle income countries. So in East Africa, first of all, there were a huge number of burn injuries, much higher than we see in the UK. And the WHO, the World Health Organization data has shown that globally burn incidence seems to be coming down, but it's still a massive problem in Africa, Southeast Asia. particularly in kids. So there were many more flame burns in children and young women, exactly as you say, open fire cooking, wearing long skirts, clothing catching fire. There were a lot of vehicle-related accidents, polytrauma. There have been some very hard-hitting um, sort of mass casualty burn disasters in Africa. You may have seen people crowding around crashed fuel tankers to gather petrol, which have then
Oh,
ignited.
right.
So
Hmm.
the numbers are astronomical. And how a service with very limited resources can deal with that is really astounding. It's hats off to all of the surgeons and nurses caring for these patients because it must be incredibly difficult with what they've got.
Yeah, lots of trauma to deal with. That's probably hard as a provider to do that. So we've been talking a lot about the diagnosis of burns, but also wanted to hear your experience on some of the leading technologies and treating them. I think you're a plastic surgeon, and you probably have some experience doing that as well. What can you share with us about some of the leading edge treatments of burn wounds?
So we're very blessed that it is a clinical and academic subspecialty. There's a wealth of really impactful scientist surgeons around the world which are advancing burn care. A big thing at the moment is the move to synthetic products in burns, away from the more traditional biological products. So traditionally, you would have things made from cows, pigs, even shark,
Hmm.
and we're now moving into a very synthetic
Well, I
era.
think a lot of times didn't it require that there be a graft taken from a different part of your body as well, which causes its own problems, or is that less frequent now with
So we
xenografts?
do. We do autografts, which is moving skin from one side of the body to the other. But we also have, there are advances on that in terms of expanding the skin. Things like autologous cell suspension, where
Mm.
skins skin cells are broken down and then sprayed on to cover a larger area um, of burns. I myself, I do not use any cadaveric skin, which it still remains popular. But in my hands, we're an entirely sort synthetic service, or we
Okay,
use the
yeah.
patient's own skin. There's also a lot of work on novel scar treatments. One that has really piqued my interest is the use of lysyl oxidase inhibitors, which are a family of enzymes involved in collagen cross-linking and scar hypertrophy. And there's now an increasing body of evidence that if you apply it to a scar, you can improve a scar's appearance because it interferes with the collagen
Mm.
cross-linking and it doesn't affect the tensile strength of the skin. So potentially we could be on the verge of a treatment which will reduce scarring, not only from burns, but from any surgery. And could we be on the cusp of scarless healing? I think that will always be the holy grail of all surgeons, particularly burn surgeons, to see what that can help. And then you have the integration of artificial intelligence, not only in depth assessment as we're talking about, but to holistically help patient treatment plans. So it can be combined with different areas to provide a very validated and individual treatment plan. It could be harnessed with different biomarkers, gen genomic analysis, allow identification of different infections in the patients or identify which antibiotics will be more appropriate for a particular patient. So there's a huge amount going on at the moment, which are really advancing burn care.
Okay. And artificial intelligence is a big deal. We're using it in our daily lives, but it's also been in the medical space for quite a while. And I think I made a point earlier that DeepView has been around. It's been being developed for more than 10 years and has used artificial intelligence. With your experience, how do you see AI playing a role in advancing wound diagnosis, and how do you think it improves from what we had before?
So I think in the context of our discussion, it really helps our decision making when we're considering surgery or conservative management. And I'm very hopeful for the role of AI in burn size assessment. It's something that's consistently inaccurate when patients are referred to us, and it can have a devastating impact. I regard size assessment as the single most important piece of information that we need for a major burn referral. It guides so much. The need, first of all, for them to be transferred to us, fluid resuscitation, the condition of the patient when they arrive. And if it's done poorly, patients are over resuscitated, their burn deepens, the fluid sequesters in their limbs, their abdomen, their chest, and their outcomes are poorer. But similarly, if the size is underestimated, we can have the same problems. An AI interface with the ability to accurately assess burn size will help address that ambiguity that we see and overall improve patient care. And as I mentioned, hopefully AI is going to play a role in providing us with these tailored treatment plans, analyzing patient data to predict healing time, optimize the fluid protocols that they need, pain management strategies, nutrition, overall leading to more effective and efficient burn care.
What you've pointed out a lot of the favorable parts of the use of AI, but are there any drawbacks or shortcomings or concerns about using it, or any cautions that we need to take when using it to make sure that it doesn't go awry?
So using AI for burn diagnosis, I think it does present several technical difficulties. The first is you require, these large, high quality data sets for the training and validation in burn care. That data may not always be forthcoming. It may be inconsistent. It may be of poor quality. And then that can mean that the accuracy and reliability of your prediction goes down. The other thing that is key is how we integrate this with our existing electronic health record system and other clinical workflows. That's going to be notoriously difficult, particularly in the NHS. One thing that maybe is not at the forefront of everyone's mind when they're thinking about AI, but is the ethical consideration. And there was a presentation at a recent conference. These systems are relying on very sensitive patient data. It raises concerns about data breaches, unauthorized access, the potential for misuse, and also whether patients have provided their consent for the truthing process. But finally, I think there's a lot of, because this is so cutting edge, very few clinicians are clued into it, and that can mean is trust an issue at the moment? They almost a black box. We don't know what goes in and we don't know how it's processed and what comes out. So how can we trust it? The decision making, it's not well understood. So until we as clinicians understand how they work, essentially we need to improve the transparency so that it doesn't erode trust in the technology, and we can then validate it and work with it long term.
I remember reading some analysis on radiologists and using AI to evaluate some of the screens that radiologists looked at, and the research found that the combination of AI and a human radiologist actually came up with the best the best diagnosis. I think it was in oncology, but it seems like that might apply here too. Do you think that's an appropriate approach to kind of cover some of those shortcomings?
Yeah, I think so, and that's sort of what we're doing with DeepView, is that we are not using it solo to make a surgical decision. It is supporting our decision making. Just like you wouldn't remove a pilot from a plane. It's about the technology supporting us as humans in our decision making, and taking some of the burden off. And it's allowing that data to be harvested earlier than we would traditionally just by clinical assessment. So yes, I think the message is that we should be using this together with the technology to support our decision making for patients. We should not be relying on it alone.
Yeah. One last thing, multispectral analysis has been around for a long time. Why has it taken until now to use this to evaluate burns? And perhaps it was used before, but in a different setting. Maybe you could share with us kind of your thoughts on why it's now that multispectral analysis is coming into its own, so to speak.
So I think there's a couple of reasons why it's been late to the past, and that's primarily due to the complexity of interpreting the data, and the challenges in distinguishing between burn in the tissues and other signatures that it may be picking up. The multispectral it captures that data across multiple wavelengths, and it provides very rich data, huge amounts of data which then need to be processed. And that analyzing that then to accurately identify burned skin and damaged skin requires very sophisticated algorithms and a good understanding of how different tissues reflect and absorb the light. The other rate limiting step has been that the data needs to be combined with that ground truthing process to reduce errors. So I alluded to how the ground truthing has been done, both in terms of histological and clinical analysis over in the US, and all of that has taken time to put together and integrate. And we're now on the cusp of a new era in burn care diagnostics.
Great. Well, thank you, Chris. I appreciate it so much, sharing your expertise and your work on the clinical trial and the paper that you wrote. Thank you so much. And again, we had Dr. Chris Lewis, who is a researcher and practitioner at Newcastle upon Tyne in Northern England. Thank you for joining us.